Next is chronic transplant dysfunction, CTD, chronic transplant dysfunction V5. A 50-year-old man is seen in transplant clinic with progressively rising creatinine. He underwent a cadaveric renal transplant 5 years ago and is currently on maintenance immunosuppression of tacrolimus and mycophenolate. His creatinine over the last year has been gradually increased from baseline of about 250 to 350 micromole per liter. He is otherwise systemically well and continues to pass normal amounts of urine with no evidence of aortic obstruction. How would you investigate and manage this patient? So gradual rise in creatinine over time is suggestive of chronic transplant dysfunction. I would review history, especially peripheral edema, claudication, urology problem, and I would confirm compliance with immunosuppression and nephrotoxic medications. Then I will also establish number and severity of previous rejections. Examination with focus on stigmata of hypertension, fluid overload, dehydration and vascular disease. Then I would ask for the following tests: serum biochemistry, calcium, albumin, glucose, HbA1c, tacrolimus levels, FBC coagulation, HLA antibody screen, check virology by PCR, cytomegalovirus, Epstein-Barr virus, urine for protein creatinine ratio, MSU cytology, ultrasound of the transplant, and Doppler study of renal artery. And then we will do elective transplant kidney biopsy. All tests are completely normal. There have been no episodes of rejection at any point in the post-transplant period. Renal biopsy demonstrated interstitial fibrosis and tubular atrophy with no evidence of ongoing cell or antibody-mediated rejection. What would be your next step in the management of this patient? The important risk factors contributing in the development of IFT or pre-existing donor disease, acute rejection, subclinical ongoing rejection, and prolonged calcineurin inhibitor exposure. And I will ask the patient to control the blood pressure, control diabetes, and prophylaxis against cardiovascular disease. Do all patients require biopsy? No. In some patients, chronic transplant dysfunction, we assume pre-existing donor disease, patient more than 3 years from post-transplant. Would it be appropriate to consider tacrolimus withdrawal in the patient? Yes. The criteria for calcineurin inhibitor withdrawal are more than 12 months post-transplant, no episodes of acute rejection in preceding 3 months, biopsy demonstrating absence of cell or antibody-mediated rejection, no contraindication to mycophenolic acid or other anti-proliferative therapy. Based on these criteria, this patient would be suitable for consideration of tacrolimus withdrawal. How would you withdraw the tacrolimus in this patient? Establish therapeutic mycophenolate mofetil or mycophenolic acid dose. Azathioprine is a reasonable alternative if patient cannot tolerate mycophenolic acid. Progressively reduce the calcineurin inhibitor dose by 50% every 2 to 4 weeks until it stopped. What are the causes of chronic transplant rejection? It's again a lot of causes you can see on the book. Thank you.